Coming up on Why Should I Trust You? The blockbuster vote by Secretary Kennedy's Vaccines Advisory Committee just days ago, which will effectively end the CDC's long-standing recommendation that the first dose of the hepatitis B vaccine be given hours after a baby is born. The new ACIP team, as it's called, argues that giving a vaccine on the very first day of life for a virus that, yes, can be passed at birth, but is predominantly transmitted through sex or IV drug use, is not always necessary. If a pregnant woman tests negative, they say, her baby doesn't need that day one shot. Wait till 2 months at least, they say. They go on to say the practice of giving the birth dose has bred mistrust for public health in more and more Americans. For much of the mainstream public health world, this decision is a dangerous break from science, removing a key pillar of the defense against hepatitis B and risking more deadly cases, with no data to support that it's the right move. And moreover, they say this committee was rigged from the jump. Its decision based inside a broader anti-vaccine effort, they say, just the beginning of a crusade to take away America's vaccines. It's an emotional conversation that is dividing many of us in this country. But today on our show, we ask, are we actually even having the right conversation? Is this change really dangerous? Is this fight really about one dose of one vaccine, or about the future of the entire childhood vaccine schedule? Are we all really using gold standard science to figure out this question? And we're talking ACIP and public health here. And finally, who would this decision impact? What's the best case scenario? What's the worst case? To help us untangle what the shift means for us, we've assembled a kind of fantasy ACIP committee of our own. We're joined by Doctors Mina, Rachael Bedard, and Craig Spencer. We'll put those questions and more to them. Look, passions are understandably running high on this topic. So strap in, it might get a little bumpy, but we've got you. Let's get started. Hey guys, welcome.
Yeah, welcome everyone.
Hey guys.
We've got a big show today. As we mentioned in our last episode, we knew going in that the Advisory Committee on Immunization Practices, that's a mouthful, ACIP, we knew that the ACIP committee meeting was going to be major, and it was. But first, who are we? I'm Brenda Adhikari.
Yeah, I'm Tom Johnson.
I'm Maggie Bartlett.
And I'm Dr. Mark Abdulmalik.
Yeah, and this is Why Should I Trust You? It's all about the breakdown in trust that we're living through these days. And as Brenda mentioned, when the vote occurred, traditional public health, things hit the fan. They really viewed this as a devastating departure from solid, reasoned, science-based policy. You had the American Medical Association calling it reckless. Michael Osterholm, he's the huge public health expert at the University of Minnesota. He called it a defining moment for our country, saying we can no longer trust federal health authorities when it comes to vaccines. And former CDC Director Tom Frieden said it was going to put millions of American children at greater risk of liver damage, cancer, and early death. While, on the other side, many in MAHA, this was I voted for this moment. As the committee concluded that not every baby needs to be given a vaccine on day one of their life. We heard from Vice Chairman of ACIP, Robert Malone, right after the vote. He said, parents, informed consent, parental choice, they all had a big win over the last 2 days. And you even had the President of the United States tweeting, this was a, quote, very good decision, saying thank you for this, MAHA. And Malone responding to him and Kennedy with mission accomplished.
Yeah, so look, today we fielded what we're calling a fantasy ACIP committee of sorts. And why? Why are we doing that? Because, look, I'll just speak for myself. It seemed to me that the discourse following this meeting last Friday has kind of blown up. It's overheated and it's caused people to really dig into their positions. And look, I get it. I mean, the conversation around Hep B is a big deal because it's about protecting our children, and it's also about self-determination and trust in our systems. It's about how we use data. And ultimately, it's about how we view risk around health in this country. So to be honest, I've sort of cocooned myself over the past few days since this decision came out, like trying to absorb it all and really understand it and trying to steer clear of my own emotions. And I'm trying to talk to all kinds of people. I've talked to some pediatricians. I've talked to some folks inside MAHA, trying to follow the facts of the situation. But the truth is, I found myself mostly texting and calling 3 people I know and trust just over and over again. And those 3 people were Mina, Rachael Bedard, and Craig Spencer. Like, we'd be up till midnight talking and texting about ACIP. And finally, I was like, You guys just need to come on the show. So this fantasy ACIP is kind of like how our show had wished the ACIP meeting had actually gone. And frankly, maybe how some folks in public health might have considered looking at this issue of the Hep B birth dose to begin with. So as we said in a moment, we're going to be inviting Craig, Rachel, and Mike on the show. And you know, they represent medicine and science and public health. And we want to ask them all our questions. But first, Tom, help us set the stage to this moment.
Yeah, so let's do some basics. Here's what the ACIP committee decided. The committee voted 8-3 to end the recommendation that every baby born in the U.S. be given the first of 3 shots in the hepatitis B vaccine on the day they are born. They got behind, I guess you could call it a more nuanced approach. They said if a pregnant woman tests negative during pregnancy, then she should discuss it with her doctor, but they no longer recommend that she automatically be offered that first dose for her baby the day they're born. They recommended that if a mom didn't do the birth dose but wants to have her baby vaccinated, then the first of those 3 Hep B shots should be given no earlier than 2 months. And for babies born to moms who tested positive during pregnancy or didn't test, they didn't know their status of the mom, they recommended that they stick with the current system and get the birth dose. And then finally, they took a second vote in which they approved recommending that parents and their doctors have the baby tested to check the baby's level of protective antibodies before going ahead with shots 2 and 3 of the complete series of shots. And these recommendations go to the acting head of the CDC, who by all estimates will adopt them, and they'll soon be the guidance from the CDC for all.
Yeah. And, you know, we keep talking about hepatitis B and what that is. It's a virus, but let's just go over a couple of quick things so everybody's up to speed on what we're talking about. It's a virus. It can cause liver failure and liver cancer. You know, in adults, it's primarily spread through bodily fluids, sexual contacts, IV drug use. But for children, it can spread from mother to baby, as we mentioned, and that can happen during birth, or they can get it from contact with an infected person who may live in the home or at a daycare center. The virus is highly contagious. Babies can also get hepatitis B from close contact with a caregiver. You know, in the daycare setting, the virus is robust, can live on the surface for up to 7 days. And Tom talked about that the CDC recommendation is no longer to give that first dose within a few hours, but the schedule now is the first dose given right after birth. And that's effective at preventing the infection from mom to newborn if in case that situation were to arise. And then the second dose is given between 1 to 2 months, and then the third dose at 6 months. And altogether, that provides pretty much lifelong immunity that you're getting by the age of 6 months.
Yeah. So the big question is, how did we get here? So in the spirit of the Christmas season, we're going to borrow a framework from Charles Dickens' A Christmas Carol.
Oh, boy.
We're going to walk through the past, the present, and our possible future brought by this change. So that means our first stop is with the ghost of ACIP past to get a better understanding of why we had the birth dose in the first place. So we head back to 1991, and this is the year that the ACIP committee recommended that all babies get vaccinated at birth in the first place. The Hep B vaccine came out in 1981, but by the time we reached 91, this independent committee of experts, which helps sets vaccine policy in America, was dealing with a really disturbing reality. Nowhere near enough adults were taking advantage of this vaccine. And Hep B had become, in their words, a major health problem, with 200 to 300,000 new cases a year, tallying up to 1.2 million cases in all. And that was leading to nearly 5,000 deaths a year from liver disease. And to make matters worse, we know that nearly half of all those with disease don't even know it. So the spread is made all that much easier. So in 91, the committee decided to make a comprehensive push to get people vaccinated, both adults and kids.
Yeah. And even at the time, we were asking people in OB/GYN to do universal testing, but there were still lots of people falling through the cracks. And it mattered because for children, it's a very different disease than an adult. So this is especially important because the risk of developing chronic hepatitis B largely depends on when you get hepatitis B. So if you're an adult and you get it, less than 5% of you will go on to get a chronic hepatitis B. But the story is very different for kids. 80 to 90% of infants infected during their first year of life will go on to develop chronic hepatitis B. And again, that's liver failure, that's cancer. And roughly 1 in 4 people who acquire their hepatitis B infection, so 25%, if they acquired it during childhood, those people will eventually die from liver disease, from a disease they caught when they were children. So back to that ACIP committee of 1991, at the time, pregnant women who were believed to be at risk for hepatitis B were tested. But as we've said, our healthcare system isn't foolproof, and neither was this. So the ACIP committee of 1991, like Tom said, recommended that all pregnant women be tested for hepatitis B. So we know, are you at particularly higher risk? They estimated that the change would mean identifying 22,000 hepatitis B positive mothers, and that could prevent 6,000 infants from developing a chronic hepatitis B infection each year. But they went further than universal testing. Testing was just one tool. They said, you know what? We have a safe vaccine. Let's also recommend the first shot of the vaccine be given to every newborn, ideally before they leave the hospital. And it's that universal birth dose that's been a lightning rod. So why? It's about protecting babies who may have been missed by the prenatal testing and those children who were catching it from interactions with infected adults in their world, like when they went home and they were newborns. So this was all part of a comprehensive push in all age groups to get the vaccination rates up at a time, again, like Tom said, when adults themselves weren't getting the shot. So getting the shots into the arms at the hospital was a super effective way to just start people off on the right foot. So they said, why not vaccinate everybody from the get-go? So that brings us to the, as Tom said, the ghost of ACIP present. And, I'm just going to take a moment here. For me, what really stood out at ACIP last week, it wasn't just the recommendation. It's just how completely different this entire process looked compared to how we used to do it. So not that long ago, there was a hepatitis B update in 2022. And for 2 years before that, that hepatitis B work group, which is, the scientific minds, the experts, they came together and they met every month for 2 years to kind of get ready for the ACIP committee. That was the norm. It was methodical, transparent, evidence-based, and a lot of that did not happen this time, quite frankly. There wasn't even a dedicated hepatitis B work group. Now the discussion came from a small child and adolescent work group, just 7 people, and then a major national policy shift without the usual deep dive into the data, the costs, and like what this means, and even that we're unpacking this to have to explain all of this is kind of astonishing because it's supposed to be a scientific advisory body. And it's really a lot of this is just, based on ideology. But on one hand, the ACIP committee assembled last week is correct that in the U.S. today, almost 60% of hepatitis B cases result from spread through sex or shared needles. And again, something that people don't realize, like 1 in 10 patients can get it just from having surgery. So again, teens, kids, young adults today, they now have virtually no acute hepatitis B. Why? Because we've been vaccinating this way universally from the 1991 recommendations, and that really changed the entire trajectory of this disease. But, there's the public and, science is one thing and the public has a different perception sometimes. A majority of Americans are highly confident that childhood vaccines are effective at preventing serious illness. But where are they on the hepatitis B vaccine specifically? KFF and the Washington Post recently found that 1 in 10 parents reported skipping or delaying the hepatitis B vaccine. It's a thing that we've heard so many times. Like, why do we need to start so soon? Including one of our guests today here, Dr. Mina. He delayed the birth dose for his child by a month. We had a whole episode on that. They also find that 4 in 10 younger parents say vaccines do not go through enough safety testing. So there's declining trust among this critical audience, the young parents who are making these decisions right now. What messages are they hearing as ACIP met last week? How many of them watched it? How many heard news about it? Right out of the gate, the mainstream media reported that this ACIP gathering was breaking from the norm, like we mentioned. There were arguments over whether America is completely out of step with other industrialized nations that do not have a universal birth dose. And we're going to get into that with our guests because it's an important topic. But the winning side framed this change as ensuring medical freedom by empowering patients to make informed decisions. But after the vote, the Wall Street Journal reported that the brand new chair of the committee was heard on a live mic during a break in the action on Friday, saying he felt the committee members were, quote, puppets on a string as opposed to really being, end quote, an independent advisory panel. He later told the Journal he was referring to pressures they faced from, quote, federal industry and medical organizations.
Yeah, it's important to note that the CDC did post a statement stating that these votes will not impact coverage of vaccines by private insurers, Medicaid, Children's Health Insurance Program, or Vaccines for Children program. The American Academy of Pediatrics did say that it would continue to advise that infants receive a birth dose of the hepatitis B vaccine, but it really makes you think about where parents feel like they're getting their information.
Right. So that brings us to the ghost of ACIP future. And we don't really have a ghost, but we do have a model. There was one published right before the meeting in JAMA. It was an analysis, as I said, based on modeling. And the authors said that they estimated that in the U.S., about 625 infants acquire Hep B each year from birth, despite the universal testing and the birth dose. And this is where we get into the future, though. They calculated that ending the birth dose recommendation for babies born to women who test negative during pregnancy, which is what ACIP just recommended, will increase the number of infected newborns by 8% or an additional 49 babies. And we'll obviously discuss that with our guests.
Wow. Okay. Thanks, all of you guys. That was a really nice setup. And when we come back, we told you about our ACIP Dream Team. We're going to have our ACIP Dream Team with doctors Michael Mina, Craig Spencer, and Rachael Bedard. We'll be right back. Welcome back, and a huge why should I trust you? Welcome to doctors Michael Mina, Rachael Bedard, and Craig Spencer. All three are great friends of the pod. They've been on several times. If you have spoken with Maha many, many times, they are independent thinkers who are not afraid of taking incoming from their own side, but they're also not afraid of calling out actions that they don't think serve and maybe even harm the American people. Dr. Rachael Bedard is an internist, a geriatrician, and palliative care physician whose work focuses on health, human rights, and justice. She teaches, advocates, and writes. You'll find her work in the New York Times, the New Yorker, and a popular Substack called The Argument. Hi, Rachael.
Hi, everybody. Thanks for having me.
Dr. Craig Spencer is an emergency medicine physician and an associate professor at Brown University's School of Public Health. He focuses on frontline preparedness in the U.S. and around the world, and he's written for various news publications, including The Atlantic and the New York Times. Hi, Craig.
Hey, everybody. Good to see you again.
And finally, Dr. Michael Mina is an epidemiologist, an immunologist, and a physician. Over the course of his career, he's been an associate professor at Harvard Medical School, as well as the T.H. Chan School of Public Health. In the height of the pandemic, he led America's Test to Treat program, which connected home testing to treatment options. Hi, Mike.
Hi, everyone.
So guys, thank you so much for being here. And we've set up this concept. You have very graciously been willing to play along this idea of our fantasy ACIP. And you guys are it. You're our fantasy ACIP. So to kick things off, you're in charge of recommending how we give vaccines to families in this country, all vaccines. So first question, would the Hep B birth dose be on your radar? Like, why or why not? Let's start with Dr. Mina.
The Hep B vaccine would be on my radar. Not because of any sort of safety concerns or anything like that, but because it's the first vaccine that babies get. It's the first vaccine that parents then think about with their babies. And over the years, we've seen an increasing number of parents throughout the country and around the world questioning whether they need to give their babies vaccines. So absolutely, I think that the Hep B vaccine should be top of mind as we're thinking about the vaccine schedule in the context of society. So my short answer is yes.
Thank you for that. Hey, Craig, why don't you take a stab at it? Would this be on your radar?
Yeah, similar to what Michael said, from a safety perspective, this would not be the first thing that I would bring up. But for those of us who spent enough time wandering the halls of Children's Health Defense last month, we frequently heard that hepatitis B was like the entry drug into the anti-vax world. I remember the first night we spoke to the pediatric PA who mentioned that he was being driven to the state capitol around COVID vaccines and that it was two Maha moms basically that, were driving him and said, hey, I want you to look at this information about hepatitis B, and asked a bunch of questions. And for him, that was his revelatory moment. So no, I don't think that there's something that needs to necessarily be relitigated on the granularity of the science. But the fact that this is such a flashpoint at this moment of time when so many more people are Maha curious or maybe anti-vax curious, or we have an increasing number of folks that are skipping out on not just hepatitis B, but on vitamin K at birth and other vaccines, certainly it'd be something that I'd want to talk about and think about how we better address.
Rachael, I want to bring you in to answer that question, but I want to ask one other thing to you because I've heard you, in our like fever texting about this. What do you think you need in order to even determine whether to take this on as an issue?
Yeah, so I think I would answer your question a little bit differently. And that's because if I think about being on the ACIP in 2025, 2026, the first thing that I think about is what are the problems that committee is trying to address in its work? We're not in the middle of a new pandemic. We're not evaluating a host of new vaccines that we're trying to make recommendations about. The problem that I think the ACIP is trying to solve at this moment in time is rising vaccine hesitancy and decreasing vaccination rates amongst kids around the country. And when I think about trying to solve that problem, I don't think about we're on this committee. The way that I would think about solving that problem is what information do I need to understand that phenomenon and where it's coming from? And then what's the right approach to thinking about how to potentially rethink policy if we need to do that, or help people feel more confident in taking vaccines according to current recommendations or whatever. I don't think we have a lot of information to help us think that through. So for example, Craig just mentioned increasing vax hesitancy, but also that more families now than sort of ever before are refusing the birth injection of vitamin K that babies get that helps prevent like deadly hemorrhage in a very small number of infants who are at risk of that. I don't understand that phenomenon. Craig and I were texting about this conversation. I'm just going to keep referring to our text, but we were texting about it earlier today because I don't think I totally understand that phenomenon. Like, where is that rising? Where's the hesitancy around vitamin K coming from? Is that something where people don't want to give shots to their babies in the first day of life? They just don't like needles, full stop? Is that because there are particular stories about the vitamin K that are circulating on social media and more people are seeing those stories? Is that a MAHA phenomenon? Is that not a MAHA phenomenon? And it's related to something else that we don't understand about who's having more children in this country, and what the stories are there about healthcare and trust in healthcare. Like, I don't think that we understand a lot about rising vaccine hesitancy. And so what ends up happening is we project a ton onto it, where we try to attribute it to causes we can see. So we say, well, this is Kennedy's fault. Kennedy's been a factor in the last 10 years of rising vaccine hesitancy because he's sort of one of the main characters in the American story about it. But is RFK Jr. why more people are refusing the Hep B vaccine now than were a decade ago? I don't know that for sure. And if I were on the ACIP right now, the place where I would want to start is by creating a research agenda that would help inform a broader conversation about vaccine hesitancy in general, rather than like, okay, let's talk about Hep B today, revisit the safety data. Because like Craig, I'm not actually that worried about the safety data around Hep B, but I am worried about the idea that more and more families are hesitant to say yes to getting their kids inoculated against infectious diseases.
Let me just play that out, though, and maybe this will throw it back to Michael. I picture in my head ACIP being this really nerdy group of scientists who are just poring over the data. And they're trying to make policy recommendations based on safety. They're trying to make policy recommendations on what's effective. Like, are we saying that they really should also be sociologists too, and maybe put aside the effectiveness data and say we need to make some of our recommendations based on the fact that there's this like decline in trust with vaccines? Like, is that a slippery slope if you start to detach from the scientific data and you start to take into consideration kind of people's feelings? Like, where does that go? Are you worried that detachment from data and science, takes us into sort of some weird places and not great places?
As a public health professional, absolutely not. I'm not worried about going in that direction. If the public isn't on board with the public health policies we create, then the public health policies and their action fall apart. I think for a long time, particularly as it pertains to infectious disease policy, there weren't other kind of tides. There was kind of like one direction that everyone was kind of willing to go on. And in large part is because the infectious diseases were debilitating. Everyone saw them. So in the 1940s, 50s, 60s, 70s, people were absolutely willing to get on board. There wasn't a different narrative to run against. That being said, actually, you go back all the way to the earliest days of vaccines, and there's always been some vaccine hesitancy, quite famously, actually. But I say that in that, we've seen the ramifications of, taking a virus-only approach to the epidemiologic public health policies and programs we put in place. And there's a reason why public health in general is a field that has sociology, it has anthropology, it has a lot to do with social and community sciences. Epidemiology is just one field if you walk into a school of public health. And for some reason, particularly around vaccine issues in the United States, we generally don't contemplate these other fields. But if you look at Paul Farmer's work, if you look at any of the work that anyone who works in other countries, especially in under-resourced and underdeveloped countries, does, way before you start talking about the intervention itself, you talk about the social context. You talk about how are you going to do things right so that the community is engaged and goes along with it. And for some reason in the United States, I think because we've had such a history of the community just kind of going along with it, we have neglected that part. But it is first and foremost the discussion whenever you do something in a developing country as a public health professional coming from the United States. So I just put that out there, like, this isn't novel. We understand that we need to work with social scientists and behavioral scientists and community engagement experts. Like, this is bread and butter public health for anyone in the global health sphere. So I find it a little bit ironic and odd, and it's a question, it's a scientific question unto itself. Like, why, when it comes to America and us, do we think that this isn't important? We saw it in COVID. We're seeing it today. Like, the fact that you even have to ask the question is like, would be shocking to a global health community if this discussion was about Haiti or Sudan or Bangladesh. It wouldn't even be a question that you're even allowed to ask. Of course, it would be number one, not number two.
Mike, you said global health, which I feel like is code for Craig Spencer. So I'm gonna ask him to weigh in. And Rachel, I want you guys all to weigh in on this point that Tom made. Craig, go for it.
Yeah, I mean, I can't agree with your point enough on that. Yeah, I give a whole 3-hour lecture about how the approach to Ebola in 2014 was complicated by a biomedical focus on how we got disease out of communities, and how only later, after my teams were attacked and people thrown into a well, did I realize that the sociocultural or the anthropological model was what we needed to lead with. And so I think that is incredibly important and resonant here. I also think, to the earlier point, like, perfect data does not create policy. I teach a whole class called The Historical Determinants of Public Health for this reason. And I talk about how in 1796, Jenner came out with this vaccine. And in 1798, you had the creation of the first anti-vaccine societies. They were massive. They were in the UK. They were here. They connected anti-vaccine activism to slavery and the Fugitive Slave Act. And what I tell my students is that in the last 200 years, the techniques and the language and the approach of the anti-vaccine community has not changed really at all. There's like fewer these and thous, and the language is a bit different. But the reality is that the principles and the approach is the same. The problem is that on the public health side, it hasn't changed at all either. And so I show a whole host of examples from the smallpox epidemic 100 years ago, when it says convincing facts with a bunch of exclamation points, and it shows the data. And it's basically like, you fools, the numbers are here. If you don't trust them, there's something wrong with you. And I think when we approach scientific, particularly policymaking, we need that science. I don't think any person here is going to argue that we don't need good data on Hep B and all these other vaccines, but we need to recognize that we cannot approach people with the understanding, the assumption that perfect data is going to translate into perfect policy, that it's going to have perfect uptake. We need to have more humility. I would rather have pretty damn good data with a lot more community trust and buy-in and ability to do community programs than perfect data with absolutely no trust or no buy-in or no ability to connect with communities.
Just to put a finer point, or to sort of agree with my comrades here, who both have experience in the global health context. I have experience working with communities in the US who have very low trust situations in jails and with the homeless population. When I work, in the fields of medicine in which I practice, addiction, internal medicine with underserved populations, we do a lot of harm reduction. And that harm reduction is premised on the same kinds of thinking and approaches that Craig and Mike are both describing here, where you recognize that you might have a recommendation based on data about how somebody ought to behave. And that is not going to be what determines their behavior. And so what you need to do is engage with what's actually happening in that person's life, in their community, and help them make the best choices that they want to make in that context. And it's this sort of constant negotiation in relationship building, in trust building, and in trying to meet people where they are in order to support them to be as healthy as they want to, often on their own terms. And I do think that because, for two reasons. One is that vaccines are such an amazing technology. And I do think that why do vaccines sort of have this halo around them where we are totally unyielding about our recommendations in this one area in defense of public health? One reason I think is that vaccines are so cool. Like, it's really amazing to eliminate, to reduce to almost zero the number of infections from something that used to kill children. It's really incredible for Denmark to have eliminated cervical cancer risk from HPV because they've been so effective at rolling out their HPV vaccine. So I think it's really hard for the public health community, for doctors, to think about negotiating around something that we are so confident in and that we know has basically performed miracles. So I have a lot of sort of empathy around that. But I also think that the attachment to how miraculous vaccines are as a technology has made it very, very hard for us to remember that vaccines are a technology we're deploying in a social context. And we have to be aware and interested in that context in order for the technology to be effective. I like the sort of comparison they make all the time is nuclear energy, which is we figured out how to create sustainable energy that's basically clean for communities. Then there was a huge amount of backlash and social suspicion and a narrative around an anti-nuclear narrative that popped up. And there were protests against nuclear plants and nuclear plants shut down. This isn't the first time in recent history that we have sort of invented fire and then taken it away. And I think we could learn from those past examples as well as we sort of think about what the risks are here in giving in too easily to anti-vax fervor, and at the same time in trying to just ignore it and shut it down.
Mark, go ahead.
To Tom's point, I just want to go back to something kind of a little bit more specific, because what is the role of ACIP? ACIP is supposed to provide independent, evidence-based recommendations on the vaccine. They're supposed to, like Tom said, review data, epidemiology, safety, balance risks and benefits. But in this meeting, unless I missed something, were there any new safety concerns brought up? We said no. Were there any new big hepatitis B data? No. Is there a huge outbreak of hepatitis B in the world? No. What is the change that we're talking about? The change is political. It's ideology. It's vaccine hesitancy. Is this the platform and the reason and the way we should be doing this? I mean, this was kind of presented as a scientific meeting and evidence-based and, presentations, but was it just advancing ideology in the big house of the CDC, which is supposed to be pristine science? I'm not saying ignore sociology, psychology, hesitancy, but is this how it should have been done? And I think we also really quickly, just for everybody's sake, we need to go over exactly what happened at the meeting and what your guys' thoughts are on these things. But
yeah. Let me go Mike first. I want to get your take on all of your take on what Mark just said. Let me go Mike first.
Yeah, I do think that the ACIP meeting definitely fell into ideology. There wasn't a lot of new data or science presented that would have enabled a new take on what the proper vaccine dosing was. And in fact, it went off the rails, particularly with vote 2, which just completely obliterated any sort of scientific basis, which was the vote on using serology to determine if people should have additional vaccines. And that's coming from me, somebody who is extremely in favor of us using things like serological tools to understand how to personalize vaccine schedules for people. So I think that the question, like, did it veer into ideology? It was like it absolutely did. But where it's not based in ideology, I think, is the question of like why this was even on the table. Why was ACIP even talking about this? And just because public health and Maha, just because we don't have like the hard data around it, it isn't a question in my mind. And I don't think it should be a question or would be a question in kind of anyone's mind that like vaccine hesitancy is growing and rates of declining the Hep B vaccine at birth are accelerating or at least increasing a bit. And that this is part of the national discussion, even before RFK Jr. was in the seat as Secretary of HHS. And so I think it's relevant to open up the discussion. The way they went about it, I think, was predetermined essentially by the end of it. They just came out with votes that, the members themselves didn't even understand what they were voting on when they voted on them. So, it completely was an inappropriate ACIP meeting that kind of broke all norms and, scientific norms, political norms, whatever it might be. But that isn't to say that we shouldn't be having the discussion. And I do think ACIP is the right arena to have that discussion. I just think the way it was carried out was kind of beyond the pale.
Yeah, I mean, I think they had a discussion, but they changed the recommendations. But I guess, Rachael, do you want to respond to that?
Well, the one thing that I would say about there was no new evidence presented. There was no new evidence of harm presented. What was repeated over and over again was that people on that committee think there is an absence of evidence of safety because they do not think that there have been adequate randomized control trials done of this vaccine. I mean, they sort of thinking about vaccines in general, but they talked a lot about the absence of evidence of safety for hepatitis B vaccines for babies. And that isn't new
true?
Evidence. I don't think that it is true. I think that we have lots of evidence, both trial data, but more importantly, from 30 years of administering universal Hep B vaccine to people, mostly in the first day of their life, that this is a very safe intervention.
Yeah, I would just say that to Mark's question, their individual comments about the trials themselves being small, low numbers, like that is true. Absolutely true. Those trials wouldn't pass muster today, but that doesn't mean, now that it's been done and it was years ago, we have hundreds of millions or billions of doses that have been given out to prove out the safety. So while their approach to the comments was true, they treated it as though the billion doses of Hep B vaccine that have been given don't exist and shouldn't account for the safety data we recognize, that's a common approach that vaccine hesitant or anti-vaccine kind of communities will take, is they'll point to the original trials and say they weren't sufficient. Whereas a public health body might say, if we could roll back time, we might do it differently, but we can't roll back time. And at the end of the day, we've now had billions of doses that show safety. So that's better, more gold standard data than you could possibly get in even a larger trial.
Craig, go for it.
Let me just add on 3 very quick things. One, it was not just them pointing to the absence of evidence that was the problem. It was them pointing to the absence of evidence and winking basically that absence of evidence was evidence of harm. I think that was problematic. 2, I feel very comfortable and confident saying with no reservation, this was 100% ideological and felt completely political by so many of the folks that were speaking. The fact that Rachael Levy posted on Twitter like the day or two after that this was about the vaccine mandates and seemed like it was some type of justification for that. It was clear what was going to happen before this even got kicked off. And I think that's problematic. And I think that undermines the whole process. I said to you that if they were debating in that meeting that, whether or not the earth was round, I would come out of that a flat earther because I could not trust them or believe anything that really was said because I don't think it was done in good faith. And I think lastly, Mark, do you remember when you and I talked with Brett Weinstein and Pierre Corey at Children's Health Defense? Do you remember what they gave as evidence of ivermectin? Their compelling evidence. What was it? How many cases? Do you remember?
It was the 40 cases that were decided in the court system, 40 cases that the judges deemed, patients would have gotten better if they had been given ivermectin.
Open, close, done. The conversation on ivermectin is over. But here with hepatitis B, decades ago, and they keep pointing to the fact that the original trials were small. I forget what the number is, 187 or something. But we now have billions and billions of doses since then. I think that billions of doses and even 187 is way more compelling than 40 or 80. So I see the problem, not just with the ideology, not just with the way the meeting was run. My 7-year-old, I've heard her play with her other friends, and I feel like they are more efficient at running a meeting. But it was the frank and obvious hypocrisy, which for me was the biggest problem. I went into that meeting, I swear to all goodness, I went into that meeting willing to change my mind, to look at the data and say, you know what, maybe I'm wrong. I came out of that meeting more convinced that that was not the place for this to be litigated, but more convinced that we need to think more about how we litigate these discussions in public.
Right. So that's why we're doing our own ACIP, y'all. That's why we're gonna litigate this right here. But here's where I want to take this conversation, because I think what I'm hearing you guys say, that no one here was particularly thrilled with how this ACIP meeting went. And no one here particularly thinks that even the recommendation was all that effective. And we can get into the whys or why nots of that in a minute. But Mike, I want to ask you, because this is why we're here, right? Because we want to do our own version of this conversation. I want to go back to why you think this was a worthwhile topic to begin with. And then the other part of it is looking at how, this phrase gold standard science is used by public health. It's used by ACIP. It's used by Kennedy. It's used by a lot of people, right? And one of the things I do hear that there's this, of course, the Hep B vaccine is good at protecting against, like, all of us against Hep B. But then there's this sort of like, and you have to get it at birth because that also protects us from Hep B. And so I want you to wrestle with that, because as we know, we've mentioned it on the show, you yourself delayed the birth dose for your own child. How do you think data is being used in this moment? And what are the themes you were thinking about going into this ACIP or our own ACIP?
Yeah, I went into this ACIP meeting this past week, ready to kind of agree, ready to kind of agree with what was going to be determined in the votes. And I was getting ready for kind of a little bit of a tussle with my public health colleagues, who are kind of really stringently on one side. And I think that there's a lot of room for there was a lot of room for flexibility. Like what we've talked about when I was on the show last with Paul Offit, and my wife and I chose to delay our baby's vaccine for hepatitis B until about one or so months. And that was very deliberate, very safe, and very data-driven. So I was thinking that was the direction the ACIP meeting was going to go, which was hey, that it was going to be questioning, do babies have to get the birth dose on the day of birth or within the first month or two of birth? And that's where I would argue that there's a very good reason to extend that flexibility. And actually, the recommendations that everyone points to for the 1991 universal birth dose, what the public health community continues to kind of fail to present to the public is actually that 1991 vote actually did offer people that flexibility out to 2 months. It said, we recommend getting it on the first day of life or sometime in the first 2 months. And that would have actually been and that's just for women, mothers who were tested and screened Hep B surface antigen negative. So they were negative. It went in a different direction, ended up in a place that really was not data driven. But one of the more important things that I think leading up to the meeting that I think just has to be said is that the public health community, in trying very, very hard to keep the vaccine schedule as it has been doing its own contorting and twisting of data. And I think it behooves us on this show and as public health professionals who are part of the institution, though maybe after this meeting will be marginalized out of the institution. I think it's important for us to call out when we as a public health establishment, establishment meaning the people who are kind of the voices, the scientists, and maybe not who were in the ACIP meeting, but it's hard to say who are the public health establishment.
But Mike, I want you to get into that because that's a big part of what we've all been. What is the data that you think they've been distorting?
Firstly, the public health establishment in the most recent, all the discussion that's been having, people have been pointing to the 1991 guidance as demonstrative of the kind of language and the recommendations that ACIP should continue making. And actually, we saw almost all of the reduction in hepatitis B happen, after that 91 guidance, that recommendation that came out in 1991. That's being what's held up as the crucial piece. And I think that that's absolutely right. Like that is when we saw all the Hep B come down. But what I think is really important to note is actually that Hep B recommendation made by ACIP in 1991 actually gave flexibility to vaccinate your child out to 2 months if you were a Hep B surface antigen negative mom. And that I think it's important for us to recognize that in 91, they recognized that flexibility was important, that the extra risk to a baby wasn't really there. If you did choose, if your mom was negative, there wasn't really evidence to suggest horizontal transfer would potentially occur. And I think one of the biggest things that I've seen in just the most recent kind of couple months leading up to this ACIP meeting is there's been a lot of, amongst the public health establishment, there's been a lot of hyperbole or just like really frank like exaggerations of what would happen if we extended the first dose out to 2 months. Now, ACIP landed on something different, but I think it's important to go back before the meeting to what was kind of being considered might happen and what people were saying was going to be super risky. And there were just like these discussions happening suggesting that we'd have thousands of cases of Hep B in infants who would get cut by Hep B containing razor blades if we don't get them vaccinated in the first 2 months of life. There was a huge number of people pointed to a modeling study that came out right before the ACIP meeting, suggesting a huge number of new cases would happen if we allowed babies to go the first month or two without getting a vaccine if they were born to Hep B surface antigen negative moms. But the reality is the evidence isn't there. Like the modeling paper was truly, and I say this from like the bottom of my mathematical modeling epidemiologist heart, was a horrendously bad paper. And yet we have every bona fide epidemiologist just cited it, probably because it fit a narrative and it was a preprint. And everyone said, well, great, this is the one piece of evidence because there is no other evidence to suggest horizontal transfer in that earliest age. And I think that that's important because maybe if we talked about these flexibilities, when a parent did come and say, hey, I'm negative, I really am not comfortable getting my baby vaccinated today, but can I come back in a month? That would demonstrate flexibility and really help, I think, certain parents from kind of going down this rabbit hole of getting into vaccine hesitancy literature and websites and whatnot. And we just took this hardline stance and said, like, no, that's dangerous to your baby, when actually we don't have any data for it. And I think that when we start, as public health professionals, start going into the data-free land, even if we think that it's the ends justify the means, then we quickly become no better than the other side of the data-free land, where you're talking about risks that aren't with any data.
Rachel, what do you make of what Mike is saying?
So I agree with a lot of it, but I think at the end, Mike talked about being in a data-free land, but actually what he had just described is not a data-free land. He had just described a situation in which data had been created in order to justify an argument. And that's to me, the big challenge here is that there are questions that data can answer and questions that data cannot answer. When you're talking about future events, the best data that you can apply is data that's already been created, and then you're modeling out into the future based on prediction. That obviously always requires a certain amount of interpretation and judgment and guesswork. And that's standard. That's how almost all policy in all realms is based in part on things that are modeled about what we think might happen in the future. But having appropriate humility about the limitations around modeling in general might, I think, help us rein in our reliance on studies like this to give us an answer. Because in the best case scenario, where that is done all in good faith and incredibly carefully, it still relies on some amount of value judgment, estimation, etc., And we can't know with 100% certainty what will happen. And so I guess the thing that I would say is I'm not nearly as qualified as Michael is to talk about the math of that paper. But what I would say is the argument that I would have liked to have seen around whether or not there was room to be more flexible about when babies receive the Hep B vaccine would not have relied on, we know with some amount of certainty how many kids are going to get sick if we make this change. It would have been a different conversation about the values that inform the choices people are already making, why we think people might be hesitant, what we think they may or may not understand about the choice that they're making, how informed consent happens or doesn't happen in the hospital setting. All of these things, all of these other questions that go back to our conversation about thinking about the social context, rather than trying to science up some certainty about what it would mean for future infection numbers.
Isn't this the lesson of COVID? Like, we've done how many episodes now? Isn't that what we've been told over and over and over and over again, that public health took the data that was there, presented as certainty, presented as a simple one-size-fits-all answer, when the American public wanted nuance. They wanted to know when you didn't know something. They wanted to understand sort of what we did know, what we weren't sure about. Like, how are we in this place again? It's from what you guys are describing here, public health response, where they were rigid, they thought they were in the right, and so they react the way they do ferociously to this change that their reaction isn't necessarily backed up in the data.
Let me just say that my answer to that is that I think we continue to try to resolve non-science problems with science. And that's the pervasive problem, and that way precedes COVID. And it is also not only a problem in public health.
I will 100% back that up as someone teaches on the history of public health. It's not COVID. This is the history of public health. Again, we have tried to use data to fix problems that are not necessarily or maybe never going to be fixed with data. And to Michael's point, I don't find it surprising that our response to what was going to happen, what we thought was going to happen, was like, let's get out a modeling study the morning of the day before, because this is what it is. This is the missing piece that people need to see. If only they know that a couple hundred more cases or a couple thousand more cases will occur, then maybe this will change the mind of people who have a predetermined outcome. And I keep thinking back to Tylenol and autism and the American College of Obstetrics and Gynecology statement after RFK Jr. and Trump got out and, had this embarrassing, dialogue and tirade about Tylenol and autism, and how ACOG came out and was like, there's absolutely no link between these things. Like, this is silly. How dare we? And puts out a big statement that says this is just buffoonery and anti-science. But then immediately the quote other side can go to ACOG's own Twitter feed from just years before where it equivocated, and years before that where it equivocated. And I think we get to the point where we want to communicate with such certainty that we hope eventually people are just going to take the data at face value. And the more we shove this down from the top without listening to people from the bottom, the louder and louder we're going to get inside of an ever decreasing bubble of us talking to each other.
Wow. Y'all, I just hope y'all know, y'all are throwing it down here. I want to go a little deeper on this, Mike, which is so I am probably the least doctory person. I mean, I don't know, Tom, maybe you and I are the least doctory people on here, right? And so here's what I've been hearing, come out from the science and public health communities, people I trust, people I've been reading for years, right? Which is that even if you are a Hep B negative pregnant mother, there is a chance that you could unknowingly give your kid Hep B, either because the test didn't capture it or because your kid could get it from a razor blade or blood or surface, whatever. And so, Mike, that has been, am I right in capturing that that's been the kind of message? And what is your, be real direct about that. Are those things true?
Yeah. And I'll just bolt onto that, Brenda, that it's if the vaccine is safe, if the vaccine is accessible, if the vaccine is inexpensive, what's the problem? Recommend. Don't force, recommend that all babies get it to avoid this slither of a chance that a child's going to have this horrible thing for the rest of their life. Why not do that? What's the problem?
I think the problem with a hard recommendation is that most physicians will do what my physician did for us when we had our first baby. We had two. And our first one, nobody was asked. The vaccine was in the baby before we were actually even asked about it. So the second time around, we said, no, thank you. We weren't planning on getting it the first time. So I think on the one hand, recommendations when made by ACIP, end up kind of turning into they have a way of translating into practice, into like this what we do, and the nuances get lost of like,
So
is it a recommendation, is it a requirement?
Now if it's fait accompli, the recommendation is really fait accompli. That now the recommendation is off for a woman who tests negative. Is it just going to sort of be the system that you don't get it, even if you kind of wanted it?
It's like, now it's going to be, I want to get back to the other question of the screening and stuff, but now it's really hard to know what's going to happen. I'm really nervous now that like they made a recommendation which is like is further than what I expected, certainly on a good day. They said like they recommend do not get it before 2 months of age, which is just like doesn't have any bearing in data either. A lot of people today are saying, well, of course doctors aren't going to listen to that. And like if mom wants to get the vaccine or dad wants to get the vaccine, they'll do it the day of or within the first 2 months anyway. But we can't be so sure. And this is the dangerous part of this new recommendation, because, give it a couple years, a few more a generation of medical students coming through the pipeline. And it's really hard. Like, what do you put in the USMLEs, the licensing exams for doctors? Do you don't do the recommendation that ACIP is suggesting? So I don't know how it's going to turn out. And it's definitely risky, because it wasn't just, hey, wait till 2 months. The reality is what they came out with is pretty much like, don't get it before 2 months, if ever. That's more or less the recommendation that they came out, and then they just went way off the
and only get one dose.
Well, they said you can use a blood test. They recommend using a blood test, which to decide if you get more than one dose, which is like, I can't even get started on how remarkably not science driven. Like there's so many reasons why you could have 10 milli-units or more of a Hep B antibody titer and not have durable immunity. Like it was with no data.
I want to bring us back, because what you're saying is what they just recommended, which is like, don't get it to 2 months if ever, and then like test if after one dose you still have antibodies or whatever. You're like, that is just bad science, and I wouldn't have gone with that. But I'm also hearing you say that the sort of public health status quo of get the universal birth dose because a Hep B negative mom could still transfer it to her baby, or within the first 8 weeks of life, the baby could still get it from like XYZ reason. And one of the things I really want you to address is the screening thing, because that feels to me like a very believable scenario where in a country where our prenatal care is just so bad that our moms actually getting screened, right? It sounds to me like you're really seesawing between these two kind of like one side public health, one side ACIP, and you're like, I don't like either of them.
Yeah, so I think what was happening, the conversation kind of got really kind of contorted on both sides. A lot of the public health folks were saying not everyone gets screened, so that's a reason to do universal vaccination of everyone at birth. The kind of MAHA or vaccine questioning people are saying, but what if I'm screened negative? Do I still need it? Let's guide our vaccine schedule based on a test result, and that's okay. And I want to be really clear, nobody in all of this has suggested that if you do not get screened, that you shouldn't get the birth dose. In other words, if you fail to get screened during pregnancy, the recommendation was and still is to get vaccinated at birth if you're not screened. So to me, that whole argument around the US healthcare system doesn't catch everyone because we don't have good screening, it falls apart, because the default, based on even the most recent recommendations made, the default is if you don't know somebody's status, if it's not sitting there in front of you saying this person screened negative, then the default is recommend a vaccine. That hasn't changed whatsoever.
And what about false negative?
What's changed is the casting a lot of doubt on like the entire purpose of this vaccine.
But
and
that's
dangerous.
That's a different issue.
Ultimately, it's the same issue, because ultimately this committee is supposed to be putting out advice for the population, not for Dr. Michael Mina and his unique situation, not for Dr. Bedard, and not for anybody. is individual situation. We are supposed to be putting out a recommendation that's going to be best for the population. And it has always been put out with this idea that there's going to be this shared clinical decision making. We've always had shared decision clinical making. You could just decline the vaccine and go on your way. But now this committee has really muddied the waters. Look at us now. Look at the 5 of us, 6 of us now. We can barely wrap our heads around this, and we're trying to parse this all out to figure out how can we make everybody happy. I mean, come on. We have seen a generation of people who have not had any hepatitis B because we've been doing this for 30 to 40 years.
I think you're suggesting, I'm not arguing for the recommendation that did come out. What I'm saying is the argument that was being made around a lack of, this is a question Brenda asked, does screening miss people and is that a big deal? And I just want to make sure that everyone's clear that the recommendation was and still is that if you missed your screen, if you're in the delivery ward and you just delivered a baby and they don't have your screen result as negative sitting in front of them, the recommendation is still to get a vaccine on the day of birth. That's still the recommendation.
Yeah, exactly.
Yeah.
But Mark, you're getting at a really important point, which is, public health is for the population, and it is, and I think in your judgment, the 20% of the population that either skips or delays the birth dose is maybe not reflective of a population. I guess my question is, well, first of all, that is a huge number of people. I just want to make that really clear, that 1 out of 10 to 20%, which is what the ratio is not a small number. I guess I would love to figure out here is are we saying that if something doesn't affect like to 80 to 90% of people, that it's not worth taking up as a issue for us to discuss? Because I think the one thing, and again, to Rachel's point, we need more data. You hear that, pollsters, researchers out there? We need more data on this, which is really getting into the why of people skipping the birth dose. I mean, Mike skipped the birth dose. Here's another woman on Twitter. She says, quote, "I was treated like an insane person for asking the doctor about the timing necessity of the Hep B vaccine for a 4-week-old after I delayed it at birth. This was a huge DC area multi-location mainstream practice. It happens all the time and it radicalizes parents for no reason." My question is it not worthwhile to actually look at a population of people that may otherwise get vaccinated, but the way that they're treated by the medical establishment is pushing them away from those very vaccines that they may take?
I think nobody's saying that, that tweet that you read or that comment that you read, it's not that they're a bad parent for choosing that. They're just choosing to leave their child unprotected for some period of time. They have to know that. They're not a bad parent. They're just making that choice. But anyway,
don't
Craig,
you think that public health is literally by their continued answer to delaying the birth dose is that you're actually endangering your child? You're like that child could get Hep B.
That child could get Hep B. Yes. You are leaving the child unprotected. Yes.
So then how are we then providing any sort of support for that family who wants to feel supported in that decision they're making?
You can be supported in that decision as long as you're accepting of that risk. And that's what the shared clinical decision making is. That's what we do. It's okay if you choose
Do we think we do that? I guess that's the question. There's a lot of people who don't think that the public health establishment does that. I want to just bring Craig in and then get back to that.
800 things that I want to say. Let me just brass tacks it here. We all believe in vaccines. Both of my kids are vaccinated against hepatitis B. Michael's kids, presumably Rachel's, presumably all our kids. And none of us waited 2 years or 12 years. I also suspect that most of us would feel comfortable if ACIP came out and recommended their 1991 language or some version of it that basically wasn't to say, put it off for 2 months and maybe ever. I think that's the big problem. So I think we're all on the same page here. The question, I guess, is, one, to Mark's point, when do we risk giving an inch and it turning it into an anti-vax mile? Because this is obviously not just about hepatitis B. I would argue that this is not about hepatitis B really primarily or at all. It's about, over the past 7-8 months, we've seen the ending of mRNA contracts, bird flu contract, ending of a commitment to Gavi, limited access to COVID vaccines, MMRV at the last ACIP meeting, leaked FDA memo on COVID vaccine deaths, CDC webpage with autism. imagine the space we're going to be in 6 to 12 months and on this podcast, and we're going to look back talking about Hep B like that was quaint, right? We're going to be like, oh my gosh, we were talking about these like tiny little things about whether it's 2 months or not 2 months. Like when we have distributors, vaccine distributors that are not going to be able to produce vaccines, when this administration finds some way to use the Vaccines for Children's program as a way to like get rid of all state mandates for vaccines as some way to tie it to funding. We saw in the Supreme Court today with the decision around New York State and this religious freedom exemptions. I think it's fine, and we should talk about and really get into the data here. But I want to contextualize in this in what the larger argument and larger problem is. I am not concerned that if we were to make it so that you didn't get your kid vaccinated and minute one or hour one or day one or week one or even month one, we're going to have this massive surge of thousands and thousands of Hep B cases in 20 years. And it's going to be horribly problematic, particularly if we have folks that are doing this and say, hey, look, Hep B surface antigen negative. I'm working with a pediatrician that I trust, that trusts me. My concern is that after I went to CHG, I wrote a piece for Stat News, and I got a whole host of very interesting comments. But one of them was from an anesthesiologist who was probably the most anti-vaccine person who messaged me. This is someone that is practicing. I looked them up. They send it from their professional email. I don't know why people do that. Please, if you're going to like send death threats, do it from your like not, work email. But like this is a physician, right? And so my question to Mark's point is like, what water does this muddy to be like, wait, what is this? Like, what am I supposed to do? Do I vaccinate now? Or does it give them some leverage to say, I'm not going to do this for physicians? And yeah, surprise, there are anti-vaccine or vax-hesitant physicians out there as well. What does this do? When I worry about the kids in those scenarios, I'm not worried about, quite frankly, like the Michael Minas who are able to say like this Hep B surface antigen negative, and I can think about this, I can think about the risk. I'm willing to accept that risk for me and my family. I'm worried about the other people that are part of this defunct system that is, if anyone's ever been to Denmark, we are not Denmark. That is what I worry about, particularly in this larger ecosystem of what Hep B looks like and what the vaccine infrastructure is going to look like in 6 to 12 months.
So is that why public health went Hulk on this? Because it's not literally about this, but it's about holding the line now because they fear much worse is coming to the vaccine schedule?
I think that that's true. My concern is that if we just keep tripling down in the same exact approach, it is less likely to be effective in 6 months or 12 months than it was even last week.
Rachel, you wanted to jump in.
Yeah. So just to Craig and Tom's last point, I do think that one of the big reasons the public health, we'll call them the public health establishment, which now sounds derogatory, and I don't actually mean it that way, has responded so vociferously to this change and to the conversation around this change is because they see it in context correctly, I think, as part of a larger assault on the reliability and integrity of the vaccine program in the United States. And there's lots of evidence for that. And I think that they're not wrong to see it that way. But to Craig's point, I'm in a conversation about this basically, I don't know, every day, like every hour, I feel like of my life, I'm sort of talking about this question this year. And people are always asking like, well, where do we draw the line? As though we hold the power to draw a line. I think the argument that I would make, that Craig would make, that I think Michael is making as well, is that we're not in a position to hold a line where we say, just kidding. We don't think that the people currently in charge should be in charge anymore. It's done. Like, they're there. And so the way in which we respond to their actions, I think, has to engage with the reality of the power that they have and how they obtained that power. And I don't think consistently reiterating that they are wrong and dangerous is proving to be a super effective strategy at pushing back on them. The other thing that I just wanted to address was a question earlier about like, who are we making this policy for? Are we making this policy for like Michael Mina? Are we making this policy for the population at large? And how are we taking into account the American healthcare system, et cetera, et cetera? And there, I think there's in a very, very different world where you were talking about an ACIP that was engaging in good faith with the challenges of the moment. You might be thinking about, what does ideal public health policy look like in a pluralistic democracy where you are trying to balance the fact that you have real respect for people's autonomy and autonomy to make decisions for their kids with what's best for the collective? And that's a really challenging question. It has been the sort of norm of the past several decades that we have increasingly oriented policy around trying to make things as safe as possible, presuming that the system is going to fail. Like, I think that is sort of how you might describe how this policy was designed. You're going to presume that you can't rely on the testing or the prenatal care or the pediatric care. So you're going to meet people at the point of care of birth and you're going to administer the vaccine. It's possible that we might orient the system differently because the social context has changed, or because the values that like Americans, are sort of expressing challenge that orientation. You know what I mean? And I think you can do that in a way that doesn't abandon population health. I think you could imagine creating policy that creates opportunities for people to exercise some agency within safe boundaries of what you think they could do. And the 1991 wording kind of effectively did do that. So I do think that like positing this as like an abandonment of the collective to even bring up this conversation is not a fair way to engage this question. I think it's not crazy to think maybe we should rethink the way that we make one size fits all recommendations to everybody. While at the same time, I do think that those recommendations have to be data informed and also just be guidelines that reflect what we do think is sort of safe, and not just let people like totally go off the rails.
Yeah. So one point that this ACIP committee brought up a lot, and Craig brought it up on Denmark, like they looked at how things are overseas and how we want to kind of mirror our vaccine schedule with the Hep B birth dose to places like Denmark. And quite frankly, I think over 20 countries in Europe don't do the universal birth dose. And one of the things in this year of doing this project with all of you is, boy, is public health like an under-resourced project. Boy, is public health a place where people don't get enough of what they need in order to serve the public. And sometimes, and I want you all to just reflect on this, that like it sometimes feels like public health uses a scientific argument when they're really talking about being under-resourced in order to have testing and, universal health care. And I'm like, why go to science when what you're really saying is when you say we're not Denmark, that's not saying that a Hep B negative woman is going to transmit Hep B like from magic, like to her kid. What you're saying is we're not Denmark because we don't have universal health care. But I want you to know that what that lands to a parent who's like hesitant to give that birth dose is like, oh, you're then putting that on me and my child, that I have to shoulder the burden of the inability of the United States to have a functional healthcare system. So in a way, like, I really get where public health is coming from, but like, do we agree that they sometimes use science as like a Band-Aid? Mike, do you want to get into that?
I do agree. That issue came up a lot in the ACIP meeting. There were in a number of different occasions, people said, should the babies kind of like shoulder the burden of like a poor screening, effort by public health and things like that. I don't have like a clear answer to it, but I do think we certainly do that. I think obviously public health should be better resourced. But I think more than that, we kind of use it as an argument. Like the Denmark thing is a good example of where we say these things, but then we're kind of like talking out of both sides, sometimes. As an example, people will say the Hep B screen is so good, it works in Denmark and everyone gets screened, and that's why there's no risk of a false negative or something because everyone gets screened. But that doesn't make any sense. Like, it's still the same test. This false negative rate is the same in Denmark as it would be in America. So I think we start talking about two different things, like a gap in screening in the United States isn't the same thing as a false negative screen. And I think we convolute these things a lot. And I think it's like where science is really great at convoluting arguments, unfortunately, especially in public health, because we're talking about many different things a lot of times. And I don't know, I do think we have to be really cautious as public health communicators, public health experts, and the average individual to understand like what it is we're talking about, to be clear about what it is we're talking about. ACIP was not very clear, but public health experts also haven't been clear. And I think it just leads to an erosion of trust all around. And that to me is like where this kind of plays out.
Craig Spencer, you had an idea.
Yeah, look, I've talked about this a lot. I think public health needs to be a lot louder. I think it needs to fight for the things that we need. The fact that it's 4% of funding in a country that spends twice as much on healthcare as Denmark and every other country is problematic. I do want to point out that, there's a couple dozen countries that don't have the birth dose recommendation. There's 116, I believe, that do, including the WHO. So look, there is some inconsistency on this. I don't know that we need to get to that. But what I do want to argue when it comes to things like Denmark, like I don't want us to try to fit our policies into Denmark so that we can think about how we change hepatitis B. I want us to provide the resources that people in Denmark get for health and just life so that we don't have to have this as a discussion, right? It'd be a hell of a lot easier if we said that your kids are less likely to have interactions with strangers and in places they don't know where they may be exposed to hepatitis B because you've got to go back to work 98 hours after you just delivered a baby. Do they do that in Denmark? No. Let's talk about those things. It's not even just universal access to healthcare or all those other things that we roll out. How much the social supports? And I think to your point, that is public health stuff. That is the stuff that we don't think about as public health. We think about as individual failing. If you can't get your Obamacare subsidies because the government says they're no longer going to fund them, or you can't figure out where to send your kids for childcare because it's too damn expensive. That's all public health stuff. And it has direct implications on the conversation that we're having right now, but doesn't get put into it because we don't frame it as a public health problem.
I think that it really underlines sort of the idea of, if you don't like what they're saying, change the conversation. Right now, public health just keeps dying on the hill when it comes to Hep B, that you have to have the universal birth dose because it's going to save lives. I think what I'm hearing you saying, and sort of Brenda sort of teed this up, is that maybe a better message for public health should be, we need universal health care, or we need better medical records that track moms, or we need universal maternal care. We need better, more, if the tests are great, but not everyone's getting the tests, we need to really hone in on that. These would be forward-leaning, action-oriented, not the sky is falling, not defending the old frame, not dying on that old hill. This may be a more effective way for public health to communicate about these risks, especially to Rachel's point, which is they have no power over these policy changes anyway. ACIP's going to do whatever ACIP wants.
Right. And I think even to sort of drive that point home more, this is the place where public health is fighting the hardest. And I will die on the hill that the worst thing that the Trump administration has done in the arena of harming the health of the American public in 2025 has been the Medicaid cuts, the SNAP cuts, and now the Obamacare extension failure that's going to come by the end of this month. The One Beautiful Bill, or whatever it's called, Big Beautiful Bill, is the worst thing that has happened to the health of Americans this year. And that is not the sort of orientation of the conversation that we are having about this at all. And Kennedy is an incredibly polarizing figure. But the thing that is going to harm children the most in this country is letting them go hungry. And this administration is willing to do that. And that is something that's a hill I want to die on before I die on birth dose versus at 2 months.
Boy, and we had folks from MAHA on who rely on Medicaid who are very nervous about these proposed cuts. So I think that's a really interesting point to end on. I just want to thank you so much for engaging with us on this conversation. We could go 7 other rounds. As ACIP, as the vice chair of our Zoom ACIP, I don't know what we ended on other than let's figure out a way to kind of fight for our country's needs better, with better data, with better information. I just want to thank you all for joining us on Why Should I Trust You? Craig Spencer, Rachael Bedard, Michael Mina. Thank you.
Thank you all.
Well, thank you.
And that was the Why Should I Trust You for this week. I am Brenda Adhikari. He's Tom Johnson. He's Dr. Mark, and she is Maggie Bartlett. Please send us questions, comments at questions@whyshoulditrustyou.net. Drop us a like, a rate, a review, subscribe to our Substack, order merch. I don't know what else. What else are we
Perfect for the holiday season, B.
That's right. There's merch. But thank you so much. We'll see you right back here next week.